I probably was introduced to breast cancer very early in my life, having a maternal aunt that was about 45, 46 when she was diagnosed, and only lived about 2 years after diagnosis, followed by a maternal cousin who I know was very adamant about getting her mammograms and things done, but at about 59, she was diagnosed and lived less than 9 months. Knew that it had a significant impact on the family and the women in the family. But then as I got older, became very interested in medicine and knew that was the way I wanted to go. Definitely had this epiphany that I needed to take care of women.
Time to embrace change and be about that life.
This is Dr. Bass with the About That Life podcast, the podcast about life or living intentionally forever. As we know, October is Breast Cancer Awareness Month. And whether you are young, old, male, or even female, breast cancer impacts the lives of many people. Now, this month isn't a month just where we sit on our haunches and not change what we need to do, whether it's through lifestyle or whether it's through awareness, but it's where we take a step forward and truly embrace understanding how we can prevent breast cancer from spreading in our community. Well, today, I'm not just going to talk to you about it. I'm going to bring you one of this country's, one of this region's experts on women's health. Not only has she done multiple things around the world, and we'll talk about that a bit later, but she has been a staunch advocate of encouraging women to engage in screening and other strategies to make sure that their breast health is a priority. Well, I am going to introduce to some and present to others Dr. Aquilla Highsmith-Tyler. How are you?
I'm fabulous. I'm excited.
You excited about today? Well, good. Well, just in general, I know you're just getting back from traveling. That was busy, but tell us your story. Because I know, right? We grew up around the same area, and we know that health prevention and those type things probably isn't as forthcoming as we would like. So what's your story?
So I'll start by saying I'm a girl from North Carolina, small town, and basically in my town, definitely the women tend to be the go-getters, taking care of business, taking care of home, and I probably was introduced to breast cancer very early in my life, in preteen years even, having a maternal aunt that was about 45, 46 when she was diagnosed, and only lived about 2 years after diagnosis, followed by a maternal cousin who I know was very adamant about getting her mammograms and things done, but at about 59, she was diagnosed and lived less than 9 months. And so even then, I think as a preteen, I probably looked at it as more of a condition of the older women, but didn't really sort of hone in as much. Knew that it had a significant impact on the family and the women in the family. But then as I got older, became very interested in medicine and knew that was the way I wanted to go. Definitely had this epiphany that I needed to take care of women in my life. And so,
and I think, and that's what's going to be my next question, right? Because we went to the same, even though we're wearing pink for breast cancer, we went to the same Carolina Blue medical school, right? We went to the same, Tar Heels. And so did that impact your decision? And I think that answer is yes, to do women's health, OBGYN and those type things. We'll talk, because I know there are people, both young and old, listening who are curious about, what made you go into that. So talk about that a little bit.
So I'll start by saying I've always had a curiosity with medicine since a very early age. Probably at 5, I knew I was going to be a physician. And
5 years old?
Yes, at 5, I knew I wanted to be a doctor without question.
Wow.
And at 12, I decided I was going to be an OBGYN, obstetrician gynecologist. Like I said, I just had this drawing to women and taking care of women, and just feeling like they were always the pillar of communities and taking care of everyone but themselves. And that was just, even at that early age, I just knew women were my focus as in medicine. And I knew that's what I would do. So I put every effort into that from that moment forward.
Yeah, no, I can see you got a degree in chemistry from Fayetteville State. You know, summa cum laude? See, I don't even know what that means. I just know it means smart. How about that? I know summa cum smart. That's what I graduated Lordy. I just graduated. Lord have mercy is what I got. No, I'm just we.
I understand. You just got to get through it.
But I saw that now as I was reading through all these accolades and different things, and our time at Chapel Hill overlapped slightly. You were way ahead. I was just coming in, still trying to figure out anatomy and physiology. But even in that, I saw when they would list the graduates with the MED program that we were involved in. Again, OBGYN was one of those things that people talked about, but not many people went into it. So what were some of the challenges that now with you, I know it was a passion for you, so but what were some of the challenges that you faced making that decision towards, that as your specialty?
I would say the biggest challenge was just staying focused. Definitely being an African-American woman, sometimes it can be difficult for people to feel that you have what it takes. And I say that in the sense that even going to Fayetteville State, getting a practically 3.99 GPA.
She said practically 3.99. She got a 3.99. just I can't even remember 3.99.
It was very interesting because it was still looked at as, I went to an HBCU, Fayetteville State University. It was looked at as my GPA was probably, if it was a PWI or a white institution, that it was more like probably a 3.4 or less. Like it wasn't really considered that my grade was a legitimate grade because of the institution I went to. And so even then I went into the medical summer program with all, gung-ho to prove and show them that, no, my GPA is good and is solid. And my sort of career path, my grades, all of them were just as good as anyone, and I could compare to anyone. And so I came out of that summer program at Chapel Hill, number 10 of the class of we probably had at least 75 minority students.
And these were
cream of the crop,
right,
from all over the country.
I was in the program,
right?
I was in the program, so not at the same time because I wouldn't have eligible to see.
We were different times.
Yeah, we were different times, but
we know we've gone the same path, put it that way. And so it was part of me going there. I had to prove that I could cut the mustard and handle going to med school there. And so being able to graduate from that program as number 10, I'm really proud of myself and was able to show them that, okay, I can do this.
They can do it.
Right. And so that's always a challenge, is proving yourself.
Now take that and move it on into internship residency, which, and I knew the tone would change a little bit because, and it does fraud. And as I'm doing mentorship and I'm telling people, I'm saying, this is just one phase of what your medical career is. It's a small phase, in the grand scheme of things. But when you look at it across the board, for many people, that's it. They get the internship and say, I can't do this anymore. They get the residency, I can't do. So what was, and I know you have that drive, right? We both come from the same place in North Carolina. So talk about that internship, residency, and from a surgical perspective, I know there's a whole lot more that goes on that, behind the curtain, so to speak.
It does. And I will sort of start by saying mine was a little bit more complicated because I actually went into my internship with a child. So I had my first child at my 4th year med school. And for that reason, I remember going to meet with my chiefs. The interns were chosen. It was 3 females. And we went to have dinner with the chiefs. And I remember one of the chiefs looking at me and said, I'm worried mostly about you because you're a single mother of a small child. And I don't know how you're going to do in this program. So I took that as a challenge and was ready to show and prove that regardless of the situation, I would ready to make it matter. And so definitely long hours. It was long before the resident 80-hour work rule and all those things that we have now to sort of protect the residents, to allow them to get the rest they need to be fit for the job. And despite that, even with a toddler, I was determined to
make it happen.
So a lot of long nights, blood, sweat, and tears, but we got through it.
So you get through residency, you get through that process, you're ready to go, and I know a portion of what's going on. Oh, okay. When you look at the camera, okay, I'll cut this part out. So you get through residency, you get through that part of the process, and I know that, you have an extensive military background, and then they took you all over the world. I saw, Germany, Japan, and various places. So talk about that, and how is women's health? And I know in the military environment, it's fairly standard, but I know being in those other countries, there were some different tenets, I'm sure, to women's health and how it was prioritized in those communities.
I will say definitely, depending on the country you're in, they may or may not practice the same standard of care as we do. Primarily taking care of family members and active duty females. A female warfighter is very important, of course, for our nation. We were able to still practice our normal standard of care. However, if we were to transfer them downtown, if they had to go into the Japanese system, and it's a different standard of care. They don't necessarily practice as we see with anything. Same with when living in England, the practices may be very different in how they do standard of care. So a lot of it was educational and just preparing the women who were stationed in those locations for what they may experience, having great working relationships with the nation that we're in, and trying to build upon those relationships were vital, because everything about life is relational, as you already know.
Right.
And so definitely having to be concerned that things would get lost in translation were always a huge concern of ours. But we were able to take care of our patients just the same and build those relationships.
And so I like the fact that you kind of juxtapose the concept of the relational nature of medicine against communication, right? And we think that those two things go hand in hand, but we know they don't, especially when it comes to prevention, right? And breast cancer comes up because oftentimes when there is, and I'll say this because we both work in the space where we want to make things more diverse, when there's a lack of diversity, meaning when physicians don't have some sort of shared kinship with their patients. I'm not saying that healthcare is bad. I'm just saying that there is a barrier there. So as we move into breast cancer and screening and those type things, why do you think that there's such a discrepancy in breast cancer outcomes with African-American women versus other culture?
I would start by saying a lot has to do with trust levels. Definitely, it is already a known and studied fact that for females, especially women of color, Black women, that our pain is not looked at as the same. So if we say that we are having 8 out of 10 pain, it is not necessarily believed by the providers that are caring for them. Or if they feel, intuitionally wise that something is wrong in their body, that it may not be perceived the same. We don't always even have the same symptoms as others. So I'll speak about breast cancer and the fact that you always hear about lumps and bumps and potential dimpling and just sort of puckering of the skin. But it may be, as a Black woman, you only get a rash and not even ever feel a lump. And so most of the time, as you are well aware, most of the studies that have been done to date usually don't include a great deal of diversity. So when you go and pull studies, you have to read them with a grain of salt and understand that we may or may not be sort of addressing our population. And for that reason, it can be hard for providers to recognize the sort of bias that they have about what a Black female presenting with certain symptoms or concerns, that they don't even recognize that they carry these biases. And it just puts Black females in a place of feeling like, well, I'm not being heard. They're not listening to me. So why would I go? Why would I entertain it? So I can't tell you, even though we're in the military system for all of my career to this point, I've done it through the military. And you would think that in the military population, because you don't have the socioeconomic gap as wide as you would see just in the civilian sector, then okay, then everything should be even killed.
Right.
It should be equal across the board. But you'll find the same thing applies, that we're most likely to have maternal mortality with deliveries. We're more likely to develop more metastatic cancer.
Right. Later presentation of things that had we have caught.
And that's even in the military, where we all get the same basically socialized medical care.
Right.
And so it is hard sometimes for people to identify that it's bigger than the dollar.
Right.
It's more to it than that. And that is the part where women have to learn, especially Black women, to be advocates for themselves.
Wow. So that's huge. I mean, right there. And I think I just got excited because, you were breaking it down so well. We jumped straight to the social determinants of health right there. We just, let's forget about symptoms. And so we got to back the bus up a little bit, but the social determinants of health, I think, impact all those things. So breast cancer, what is breast cancer and what are some of the common symptoms? And I know you said they're different between African Americans and other folks, but I know everyone can experience it differently. So what is breast cancer and some of those common symptoms?
So when it comes to breast cancer, it's just like any other part of our bodies. It's full of different types of tissues and cells. And when those tissues sort of grow out of control, then they can go from being normal cells to malignant or cancerous cells. Mm-hmm. And you'll hear oftentimes, and patients get very nervous about certain words like neoplasms, and may not know the difference between benign versus malignant. But when we hear the word malignant, that is representative that it is cancerous, and it is a huge concern. For breast cancer, of course, you have about 4 million survivors or people with diagnosis of breast cancer in the U.S. alone. It is the second most common cancer next to skin cancer for women. And so in a woman's lifetime, she runs the risk of about 1 in 8 women getting it. So it's not as small as some people think. It's
about 12%.
Your lifetime, 12% chance of getting it. Now, some people would look at it at the other end of saying that it's, oh, well, I got an 88% chance of not getting it.
I wouldn't look at it.
And so you have to understand.
Because I know 10 women. If it's 12%, that means 1 of the 10 women that I know are going to have breast cancer.
Right. And so now it's a matter of there is no real way of saying, I won't get it. And when it comes to breast cancer, you have to be prepared to just know your breast well, be willing to do self exams, and 9 times out of 10, you will find it. Now, when it comes to the symptoms you will see with breast cancer, usually you may notice a lump or bump, a raised area, tenderness even. Some people will say, well, cancer doesn't hurt. It's not painful. Mm-hmm. Cancer can hurt. It will be sometimes a painful lesion that women experience. And what sometimes women don't realize is you even have breast tissue under your armpits. So you may not ever feel a lump or on your chest wall or within the actual breast tissue itself. It may be living under your armpit where the problem lies. So it is vital that women check all of these areas, from the chest wall to the actual breast tissue under their armpits, in that nature. When it comes to other things that you can see, sometimes it may just be a redness or irritation even. Mm-hmm. It may be a matter of having like dimpling or puckering of the skin, because it's almost like the cancer sort of
bring it.
Yeah, sort of enveloping itself around the skin and sort of pulling on it and tugging. And so it can be very, very painful for women. I later experienced, now that I'm older and thinking that it was an older lady's condition, one of my cousins that were basically my ride or die, as I call it, hung out and did everything together. And she was diagnosed at 41 with breast cancer. She's slightly younger than I am. And she currently is doing relatively well, even though she has stage 3 cancer. She's now at least 6 years out from the diagnosis. And we talk quite often, and still when I go home, we manage to go dancing. So it's amazing to see the difference from almost a decade or so ago of my aunt and cousin, who literally lasted 9 months to 2 years, to have a cousin that now has survived well over 5+ years post-cancer diagnosis, even with a more a higher stage or stage 3 cancer. So you can definitely see that we've made progress, but we still have a ways to go, because the biggest problem is just getting women, especially Black women, to understand the need for screening and to stay on top of those things.
Now, what are some of the biggest, now we talked about symptoms, right? And you want to get that? Or are you good? We talked about symptoms. So what are some of the risk factors? Because one of the big risk factors for heart disease and other conditions, prostate cancer, is family history, or your genetics. And that's something that you can't do anything about. You can't change who your parents are. And in many cases, you can't change what the trajectory of your genes are.
Exactly.
But what are some other risk factors that people maybe can change or can modify to reduce their risk of breast cancer?
Right. As you mentioned, risk factors that we can't change are genetics, as well as the fact that you're female. Men can get breast cancer, but it's more like 1 in 1,000 compared to women. But those two things we can't really change. I will say some of the things that we feel you can change. It has a lot to do with lifestyle. As you can imagine, you want to avoid those, top 3, whether it be hypertension, high cholesterol, diabetes.
This sounds like a heart disease talk. This sounds like a heart disease talk.
Pretty much, it's the same concept. And this is what people fail to realize. Cancer loves sugar. For the most part, cancer cells loves sugar. So when you have a diabetic, when you have an obese person, when you have hypertension and high cholesterol, usually that is a person that is basically in sugar overload, and for that reason, more likely to develop cancer. And so I think sometimes the hard part to that as well is, as Black women who may be trying to maintain homes, maintain children, living extremely busy lifestyles, don't quite do the necessary self-care for themselves as they attend to the family needs. And for that reason, hypertension, diabetes, high cholesterol, obesity becomes a big issue for them. Just the stress that we go through with all of those factors are significant players in getting breast cancer. What people fail to realize is that we do believe that a person with diabetes probably has a 50% higher chance of getting breast cancer just because of that sugar factor. On top of that, 70% of breast cancer is sporadic, 70 to 85%. That only needs about 15% or less to sit in the category of hereditary and genetic. So as much as we love to hear about BRCA1 and BRCA2, that's not the biggest players in this equation of the cases that we see. So it's sporadic. And that's what I mean when you say you may only have an 88% chance of getting it. It's very sporadic. So you don't know whether that's going to land on you or not. And definitely, if you are not controlling all the factors that you can possibly control, then you're sort of, struggling with the odds. You're playing against odds. So it is a big, big factor that we really need to get after our health and our style of living, controlling our weight, even if you are diabetic, to get it under control and get a normal hemoglobin A1C, is still going to make a difference in reducing that risk for breast cancer.
So another push for lifestyle. So let's just say I have a cousin or a friend or someone comes to me, or one of my patients. I'm in cardiology clinic and I'm, listening to the heart, and she says, I feel a lump or something like that. What is the next step for that person? If you have an abnormal self-exam or something like that, what should that next step be? Because this could be something that providers need to tell patients, hey, ma'am, because I'm a specialist. I'm not normally asking. I mean, we'll talk a little, but for the most part, I'm making sure your heart's okay, right? But
agree.
What is the next step if you have an abnormal exam?
So I would definitely say that the next step would be to reach out to your primary care manager. For some women, that may be a family practice doc. For others, it may be their OBGYN. So between those two primary subsets is usually where you would find, which is where you should be directing a patient to go. and something that we should be saying to the patients at all times, even if they recently had a mammogram, any change in symptomatology, any lumps felt, regardless of how recent a mammogram may have been done, still warrants that woman to be seen and evaluated for it. So I would never want someone to think that they're clear and free because they've had a recent exam or recent mammogram done. So the first recommendation would be to see their primary care or women's health provider in order to get their evaluation done, because there's a difference between a screening mammogram and a diagnostic.
Okay, well, go ahead and talk, because and this lets you know, how didn't you know? I didn't know. Like, I was talking to one of my patients, and she said, well, I'm going back for another mammogram, and it's this. And I'm like, well, man, what? Because I know in cardiology, we sometimes don't get diagnostic studies or have another. So talk about what the mammogram is and the difference between a screening mammogram and a diagnostic.
Definitely. So with the screening mammogram, pretty much any woman can pretty much just go and schedule their screening mammogram. There's no requirement to see your provider or your PCM for that. And it basically should start happening around the age of 40. Okay. So from 40 on, every year a woman should be getting a mammogram. That is I'm part of American College of Obstetrics and Gynecology, and that's our professional statement and stance on mammograms, the screening ones, that is. And so with the screening mammogram, once those results come in, if everything is normal, then typically the woman would have that next follow-up a year later. Now, in a woman with a family history, or maybe she has had significant issues with her breast in the past, even if there were benign breast disorders, she may start as early as 35 with mammograms, but those would require her to have that conversation with a provider in order to be getting screening mammograms prior to usually the age that's set according to different task force statements. So 40, usually there's no question about it, a woman can walk in and get a mammogram without anyone sort of having to authorize that mammogram. And with the screening mammogram, they may find something that looks like they need to do further workup or evaluation for. And at that time, usually that radiology department will call the woman back in for a diagnostic mammogram. And with the diagnostic, they're just taking different layers, more assessments. It may lead to breast ultrasounds as well, because depending on how dense the breast is, the mammogram may not be able to pick up everything. I'll take a step back and say what a mammogram is for women that may have not experienced it yet, had the pleasure of getting a mammogram yet.
And I want to say this before you say it. I was at the hospital that we work at, and I was talking about mammogram. Oh, yeah, just go. And they were like, don't you realize this is an uncomfortable? And I had no idea. And I don't want people to know I didn't know, but when they were talking to me about it, I'm like, oh, okay, that doesn't sound very pleasant. And I was like, oh, okay, well, so mammogram.
So with the mammogram, you are going to go in and basically stand in front of a machine in which it's almost like two plates that you will have your breast position on in order to basically make a sandwich. And they're basically smashing the two plates down in order to...
That's what they say, smashing.
In order to fully see all of the breast tissue within that region. And it is uncomfortable. It's different angles that they're sort of making this sandwich, as I call it, in. And with that being said, definitely women with smaller breasts is usually more uncomfortable because they don't have as much tissue to put between the two plates to start with. So it is not a comfortable procedure at all. But I would only say that it's less comfortable to deal with the treatments that come with breast cancer. So that is all of a few moments in time to live in that discomfort. For women that have had babies, it's way more uncomfortable to have a baby. Is way more uncomfortable to do a lot of things, but I would rather know that I've accomplished early detection of cancer to avoid chemotherapy and all of the other different treatments.
And I know you're not an oncologist, but I know you counsel women on those pathways, and you talked about it to say, an ounce of prevention is worth a pound of cure, right? And that's that push. So you find a lump, they do the diagnostic, they're concerned about cancer. And then you said something a little way, you said, but depending on the stage, and from what I was reading, African American women are more likely to present at a higher stage. What is this staging process?
So when you have staging of breast cancer, usually early detection is more stage 1, and you have sort of that middle ground of 2 and then 3. And once we're at 3 and metastatic levels of cancer, then usually most of the things we're doing, we're not able to cure the cancer at that point. Mm-hmm. We're only able to treat the symptoms and try to control how fast it grows and try to just better your life at that point. So for Black women, unfortunately, we tend to catch it at that latter stage, more along those metastatic lines, and it makes it where now we're sort of trying to deal with the symptoms, trying to just improve our quality of life to live with cancer. And we will usually be on medications for the rest of our life, however long that may be. So definitely the earlier the detection, the better. And it can result in just you needing just a lumpectomy, where I'll take a step back. When we find anything on any of these screening or diagnostic modalities, such as mammograms or ultrasounds, we usually are going to do a biopsy. And usually it's ultrasound-guided biopsy.
Okay.
So you will go in either with a radiologist that will do the biopsy. Sometimes you may be going to a surgeon that specializes in breast tissue to do the biopsy. But the biopsy will come first in order to make that diagnosis. And upon making a diagnosis of cancer, then discussing your treatment options. Knowing, like I said, the earlier you catch it, surgery may be all that you need.
Okay.
If it has not spread to your lymph nodes or involved a great deal of your chest wall, then you have a higher likelihood of being cured completely from that cancer.
Okay.
Once again, for stage 2, 3, when we're at metastatic levels, now it's a matter of trying to treat the cancer itself, and you may be treating it with chemotherapy first, radiation therapy as well, all of these different modalities to try to control it. Breast cancer is unique because it can be hormone related, hence why women are more likely to get it, because of estrogen receptors, progesterone receptors that we carry. So if it's estrogen positive or progesterone positive, there may be certain hormone modulators that women take in order to control it. So with all of these different facets in which the type of breast cancer it can be, knowing how sporadic it is, knowing that the earlier the better, like I said, that time of discomfort is the
worth
the least of concerns in these situations, and it is well worth that discomfort to ensure that we catch this as early as possible.
Wow. Now you've broken it down. I mean, you've given a master class on breast cancer evaluation, screening, risk factors, symptoms, and treatment. So now, as we round this out and we think about the disparities that exist for African American women or in communities of color, in large part, when we look at, again, and this isn't breast cancer, but it still speaks to that social, the maternal fetal health crisis, which again, in this country, African American women are at the highest risk of dying just from giving birth, right? And you look at all those things, what can we do as a community? Not experts such as yourself, but as a cardiologist or as a primary care or as just a caring husband, brother. So, what can we do or individuals do to help people to get screened or to encourage them? What can we do?
I think a lot has to do, once again, it goes back to relationships, making sure that you build strong relationships within your community. No matter what your job is, you can have a place to sort of help and participate, whether you somehow or another drive a bus and take women to get their mammograms, whether it be that you ensure you pass the information along. Like, you'll be amazed at just different influencers and people's social media platforms in which, when there is some mammogram sort of event going on, and they sort of make sure they spread the word and get the information out there so they can get as many people to that location at that time, trying to assist struggling mothers potentially who can't really find the time to break away. If there was some way to have, a temporary daycare to watch children as they go and get the exams done. Like there are so many things that we don't have to be directly engaged in the medical part, but just allowing that avenue for them to get there even. So a lot of that plays a factor in it. Having these types of conversations, of course, are important. Just continuing to contribute. You will find a lot of different forms that are specifically speaking to minority platforms. I will say from a metastatic breast cancer, since we're talking about that latter stage, it literally has a metastatic breast cancer awareness day on the 13th of this month, on this coming Friday, because of the fact that there were so many breast cancer support groups before like 2004 that existed, but none of them for really women in the latter stages of cancer. So for those women, there wasn't a whole lot of research being done on how to take care of them. There wasn't any of that. And all of a sudden, they decided that there was a hole that needed to be filled. And they developed the Metastatic Breast Cancer Network for that reason, and eventually had descended to establish a day for metastatic breast cancer awareness on the 13th of every month, starting in 2009. So we don't realize how much control and how much power we hold and being able to contribute. And we just have to find our niche.
Wow. So again, and there you go, dropping another gem, Metastatic Breast Cancer Awareness Day, the 13th of October.
Every year.
So coming up.
Yes. So wear your pink.
Wear your pink. Huh?
Wear your pink on Friday.
Can I come on?
Wear your pink on Friday.
All right, let me pink on Friday. Well, it's been just a great conversation. Now, I know I'm going to have more questions. I know you have to run. But if you had, let's say, 2, 3, 4, 5, 6, 2, 3 things to leave people with so that they can be empowered, be energized, be educated towards preventing breast cancer. And then if they have it, knowing those right steps, what could they be?
I would first start with just saying, listen to your body. You have to be attentive to yourself. Like I said, it sometimes can be very difficult as women who are managing a lot of things to focus on ourselves. But taking the time and becoming aware with yourself, knowing your body, and not taking no for an answer. If you notice something, if anything seems off, like I said, it could be a rash that's not even anywhere near your breast that is problematic for you. You need to be seen. You need to speak loud. Do not allow someone to just sort of make it seem as if it's minuscule and it doesn't matter. Address it. And I would also say, in that portion of taking care of ourselves, we have to understand that our health and what we do day to day, each day matters. We love to try to start these fad diets and do things to quickly make change, but it is one day at a time with our lifestyle. And we have to make a point to understand that and be willing to show grace, mercy, if we have a day that we don't do well. But our goal should be that we change our life and the life, how we live, not only for yourself, but the legacies that you will leave behind. So the more you focus on your health, exercise, eating right, avoiding sugars, and doing your part to take care of you and keep your medical conditions under control, the better off you will be. And I would leave it at that.
Wow. That was powerful. That was moving. You're going to end up messing around being a co-host because I'm motivated now. I'm motivated. But first off, thank you for allowing us to have this conversation. I know it is going to be impactful. It was helpful to me. And, I'm going to just ask you on camera so that way you can, which we got another women's health issue coming up. So you're going to be pinged for that one too. And I like how you embraced it in the concept of lifestyle, advocacy, lifestyle, community, and communication. So you got to come back.
Oh, not a problem. I would love to. Thank you so much.
No problem. Well, this is Dr. Vance with the About That L.I.F.E podcast, and what you just heard was a masterclass on breast cancer awareness. We not only talked about the symptoms, the risk factors, the diagnostic test involved, we also talked about the limitations for treatment. But as much as we have had this conversation, it should be couched in the concept of understanding that you need to be your very own best advocate. Not someone else, but you going out there and making sure that you're getting the testing that you need, that you're asking the questions, and ultimately you feel empowered to make a change in your own life. Whether it's through lifestyle changes, improving education, or increasing the engagement that you have an opportunity to be the very, very best version of yourself. Thank you, and have a delightful rest of your day.
We truly hope you enjoyed today's episode. If you did, share it with a friend, leave a comment, and certainly join us for our next episode of the About That Life podcast.